Thank you, Dr. Alam. I hope you can all hear me. I couldn't hear you very, very well, but I want to make sure that the audio is clear for everyone. It truly is an honor to be with all of you to deliver this 22nd annual John Lewis Interventional Lecture for the Texas Heart Institute, Baylor St. Luke's Medical Center. It really, truly is an honor. And interesting for an interventionalist such as John Lewis, who was one of the most fastest and furious interventionalists, to go from intervention to prevention, I think will be music to the ears of some of the colleagues there at the Texas Heart Institute, Baylor St. Luke's, especially Christy Ballantyne, who is a mentor, and I really, really admire his incredible impact. But he really is impacting all of us. And the fact of the matter is that prevention is a must if we are to have durable intervention and optimize our outcomes. It's really, really important for you to note my disclosure specifically to my institution for all of those roles that I have. So coronary artery disease and myocardial infarction, as we know, heart disease is the #1 killer of men and women across the globe. And as we look at this graph, we must all really feel good. There's been a tremendous reduction in cardiovascular morbidity and mortality, even if you just focus on coronary artery disease and myocardial infarction. And a lot of that work came out of Texas very early days with revascularization, especially on the surgical side. And I know you're all standing proud, and Dr. Willerson, absolutely one of incredible pioneers in the field. But over the years, with all of these studies, we've made an impact. But it seems that for the last few decades, the curve is flat, and there is this residual risk that we must target if we're going to get to the best possible place. And that is a big, big ask, because the residual risk isn't just coronary risk. It really is about the cholesterol, inflammatory, thrombotic, triglyceride, hypertension, diabetes, and obesity risk. And what I'll try to do in the next 45 minutes or so is to try to kind of go through all of these pathways and tell you what's in store for us, because I think we're absolutely determined to get that number down and bring that residual risk down to a 0. But perhaps we can even then move away from intervention in some ways and go to prevention even before intervention. So prevention before intervention, so we could have the least number of patients requiring that kind of revascularization and coronary events and those things. And then, of course, if they do, we must continue with the residual risk that's listed here. And the fact is that we've got lots and lots of work that has already been taken place, and hopefully it'll get us to where we need to go. But let's start with that thrombotic risk. The cornerstone of treatment for all ACS and PCI is antiplatelet therapies. And there's no question that we have made huge impact over the years in dealing with all of the receptors, including the thrombin, the thromboxane, the glycoprotein 2B3A, the P2Y12 receptor, to basically handle adhesion, activation, and aggregation of platelets, and understanding how important it is, what a vital role platelet inhibition has in promoting and reducing our very important ischemic events. But with that comes the risk of bleeding, and balancing that and finding the sweet spot has been our quest over the last decade, because we've now noticed that as we reduce ischemic events with these potent agents and keep adding and stacking antiplatelet, antithrombotic, anticoagulants on top of the regimens, we're increasing the risk of bleeding. And once a patient bleeds, we stop all of their life-saving therapies, including the antiplatelets, including statins for whatever reason, and we expose them actually to ischemic risk. So understanding the right timing and really finessing our treatment and knowing our patients and where they are in their ischemic and bleeding risk profile, given what they've received, as well as who they are and how they present, and their comorbidities, becomes paramount in finding that sweet spot. And we're finding more and more that perhaps less is more. And this is the reason why all of these shorter duration of antiplatelet therapies and even aspirin-free strategies going to P2Y12 monotherapies have been center stage over the last 5 years. I could say I've contributed to this with the Twilight trial. That was a prospective randomized double-blind placebo-controlled trial of withdrawing aspirin in high-risk patients undergoing PCI who would be going home on aspirin and ticagrelor because they were high risk. And after a short period of DAPT, we dropped aspirin and went to TICA monotherapy instead of having the patients continue with TICA plus aspirin in a double-blind placebo-controlled fashion. And what we found was an incredible reduction of bleeding, about a 55% reduction, and no change in the ischemic events. And then many followed with multitudes of these very, very important ongoing trials that are coming in the future, large numbers that are absolutely even going to a shorter duration from down to a month, even at the time of discharge with some of the potent agents, to where we're going now in terms of an individual patient data analysis of the already published data that we published in the Lancet, looking at ticagrelor monotherapy in over 23,000 patients, showing that important risk reductions, especially in the acute coronary syndrome patients, and very important non-inferiority, nothing to lose, no tax to pay when you, in terms of ischemic events, if you drop aspirin and you keep the patient on a potent agent. That aspirin is basically doing nothing but exposing patients to more bleeding. And it was for this that we had a very interesting editorial. Is this the conclusive evidence for ticagrelor monotherapy? And I think we learned very recently the ACC/AHA guidelines that really were questionable on this in 2023 came to a very direct and important class 1 indication for ticagrelor monotherapy, class 1 single antiplatelet therapy after a short duration of dual antiplatelet therapy with aspirin and ticagrelor. So you are understanding what's going on in the acute coronary syndromes. And I think we also saw a 2A indication back in 2023 with some of these patients who are at high bleeding risk with a shorter duration and going to any of the P2Y12 monotherapy as one of the choices. But all of that aside, we still haven't seen uptick of dropping aspirin. And we continue to see the thrombotic risk that is very much paramount with all of the data that we have. And now there was some evidence that perhaps a dual pathway inhibition can take care of this important residual risk with combining anti thrombotic therapies like factor 10A in the coagulation cascade and a P2Y12 inhibitor in the platelet activation cascade in what was called a compass-like strategy, where the trial was even stopped early because of the reduction in mortality in these 27,000 patients in whom they received aspirin plus rivaroxaban on top of their antiplatelet therapy and did beautifully well in reduction of their ischemic outcomes, but there was a higher risk of bleeding in these patients, and hence only about a 2B recommendation for high bleeding risk patients. And in those patients who have a high risk, you certainly could give them a 2A recommendation. So the expense of bleeding stopped this very interesting compass strategy at a halt. What are we doing now? Is there a way to uncouple hemostasis and thrombosis. And that's the future. Is it possible? Well, there's hypothesis. Hypothetically, the answer is yes. Have we proven it? No. But this factor 11 inhibition is very, very interesting because it's implicated in both consolidation of hemostasis as well as amplification of thrombosis, getting into the both intrinsic and extrinsic pathway, extrinsic being triggered by tissue factor, intrinsic by contact inhibition, and interestingly enough, the feedback allowing in factor 11 to reduce the formation of pathological thrombi with a hypothesized preserved clotting where there needs to be in response to bleeding. Wow, isn't that the holy grail? Reduce ischemic events without increasing bleeding? We need proof of that. And this is the portfolio for factor 10A inhibition. Huge portfolio. I would say close to like 70,000 patients being studied in both the Librexia program and if you look at this, you could see this in the small molecules, in antibody, and in ASO. You could see large numbers of patients being included. But if we were to focus on PCI and ACS, it would be the Milvexian and Librexia program. They're going to do about 50,000 patients in AF patients for stroke reduction, in multitudes of patients with ischemic stroke risk, previous stroke for primary outcome of reduction of ischemic stroke, and in acute coronary syndromes with 16,000 patients who had a recent ACS, underwent PCI or not, for primary outcome of MACE. So very, very interesting. But where are we beyond antithrombotic therapies? And that's where we go towards the lipid reduction. LDL, the lower the better. I think we know this very, very well. And this audience doesn't need me to tell them when you have Christy Ballantyne there right next to you. And the guidelines are telling us we need to even go as low as less than 55 milligrams per deciliter, a class 1A indication for LDL reduction in acute coronary syndromes. That was the ESC guidelines in 2023. And just hot off the press, literally a week ago, a class 1 indication for non-statin lipid lowering therapy in patients with ACS on those who have an LDL greater than 70. And I think this is very, very important to say we need to go lower in these patients who are at high risk. The residual lipid risk is atherogenic, it is thrombogenic, and it is rich in cardiovascular events. And to get that number as low as possible is where we're going. And we need to be even more aggressive in higher risk patients. And of course, these are the kinds of things that one would imagine. And now we're moving very, very fast and forward towards these very important PCSK9 inhibitors and maybe even HDL increasing therapies, multitudes of the therapies that are coming forward. And who are those? Early, striking it hot and very early. And they say, I just came from Italy, where they say strike early, strike strong, go for that reduction of the LDL, especially when a patient presents with an acute coronary syndrome. Are those patients who present with an ACS who are already on high dose statin, who have recurrent events, who are statin intolerant, and those whose reduction still is above the goal of where it needs to go. And we know this data from alirocumab in acute coronary syndromes from Odyssey outcomes, where the longer we wait, the better the benefit gets. The curves separate as we go into year 2, 3, 4, and probably beyond. The longer you percolate with lower LDL, the lower your event rates. And this is very, very interesting, especially knowing that the benefits are even greater early after an ACS. And very important to note that the effects on plaque may exactly be where these molecules are working. The short-term effects of PCSK9 inhibitors on coronary plaques have been very well elucidated, where we've seen now this is a very small groups of patients, but you start to see the profiles are well known in understanding lower LDL, lower LP(a), but importantly, by our imaging, the plaque content becomes less lipid rich. And we saw this in the non-infarct related arteries in the alirocumab in MI patients, alirocumab versus placebo, where they looked at intravascular ultrasound and evaluation of the lipid with near infrared spectroscopy, chemograms, and optical coherence tomography, looking at that fibrous, the thin cap fibrous atheroma. And what they found, without any question, is that with the use of alirocumab versus placebo, there was less atheroma volume by intravascular ultrasound, less lipid core burden by near infrared chemograms, and a higher and a larger, thicker fibrous cap measured by optical coherence tomography. So these are really significant. For the first time, we're seeing solid evidence with lowering acutely, even in an acute coronary syndrome patient and MI, a very, very important reduction of the plaque morphology, which I think is tremendously important. And it is for this reason, striking early, immediately after an AMI, Evolve MI, evolocumab very early after MI, is conducted, completed its enrollment, and now is in the follow-up stage. This is a large-scale, randomized 6,000 patients to evolocumab at the time of the MI versus routine clinical care, and with a primary endpoint of MI, ischemic stroke, or arterial revascularization and death, and a very important time to event analysis with a median follow-up of 3.5 years. So we'll see the results of this to see what we need to do in terms of early introduction of these PCSK9 inhibitors. But there are also other areas to go to, and very important new perspectives in targeting the mRNA degradation with small interfering RNA, or ASO. And I think this is where I think the field is going in terms of reducing PCSK9 inhibition, or ApoC3, or ApoA, or ANGPLT3. And you could see that these are absolutely underway. But let's begin with inclisiran as a small interfering RNA. This is a very, very fantastic, huge program. They're already up to, like, I don't know, Orion number 18 or something, with multitudes of evaluation of different patient populations, showing without a doubt a clear reduction in LDL cholesterol in a very swift way in only 2 injections yearly. And I think this is obviously the work of Dr. Ray and others and colleagues that showed this very important small interfering RNA inclisiran in reducing LDL cholesterol levels. And very interesting to see that the early introduction of this could be incredibly important in its efficacy. These were a very interesting study called Victorion Initiate, where they brought in these patients with elevated risk, maximally tolerated statin or statin intolerant. They randomized them to inclisiran, added immediately to those not on at LDL cholesterol goal or usual care. And this kind of early introduction, not only with inclisiran first, now these are small numbers of patients, but it just shows you implementing it earlier in the treatment pathway allowed for reduction of LDL cholesterol without any new safety concerns, and got them to goal versus the usual care earlier and more swift, and didn't have any issues with statin discontinuation. So these are all great, but everyone is waiting for the outcome trials because we can't say anything about their MACE until we see the upcoming outcome trials in inclisiran, which is the first one, which was Orion 4, that's being conducted over at Oxford and Timmy Group with 15,000 patients with stable atherosclerosis. Victorion 1 Prevent, that's being conducted under Novartis's oversight, 14,000 patients, again, with a hard endpoint of death, MI, or stroke. And then Victorion 2 Prevent, which I'm involved in, 17,000 patients for very similar three-point MACE of death, MI, and stroke. Imagine the totality of the evidence as this is coming forward. And now you're telling me, well, what does this have to do with our interventional procedures? Well, it's because we are now doing a V intervention trial. Eligible participants who are having PCI or peripheral vascular intervention are going to be given before their hospital discharge their usual care, everything as the interventionalist would do, but they will leave the hospital with either inclisiran injected or placebo, and then have a follow-up treatment followed every 6 months with a time to event analysis of their recurrent events and all of their events for this very important primary objective of superiority of getting them early onto the therapy after an intervention so that we could prevent events and make these interventions durable. And I think this is a really, really fantastic team effort between 3 AROs, Duke, CPC, and Mount Sinai, working together with Novartis to bring this. And I hope that we could get you guys to enroll patients for us, and let me know if you're interested to make sure you're part of our enrolling sites. And then, of course, we have been mesmerized by the fact of what can we do with HDL function? Can we improve the function rather than the number? And the Aegis 2 trial tried exactly that with a very, very robust clinical trial of large numbers of patients, 18,000 plus, who had either an acute, had to have acute MI, post-MI patients, multivessel disease, additional risk factors, randomized to placebo versus an infusion of ApoA1, as CSL 112. And this was to look at improving the function of LDL in removing and hopefully removing lipid out of the plaque. And unfortunately, we did not meet statistical significance in improving cardiovascular death, MI, or stroke, even though, I mean, every time you see a p-value of 0.1, you really want to bang your head against the wall. Should we have had more patients? Should we have followed up longer? Should we have, what should we have done? But the truth is that this did not pan out, unfortunately. But I wouldn't throw this baby out with the bathwater, because I think focusing on the HDL and getting there, especially in those patients who had hyperlipidemia. So in other words, going again after those lipid-rich patients, that the idea of getting maybe their LDL a lot lower, or imagining that something like this could work, because this post hoc analysis did show us that in patients with an elevated baseline LDL, that the drug did work and had an important impact. But unfortunately, this program is not continuing, and we have to kind of think about this. But there's a lot more, and I think that meets the eye for us to think about CETP inhibitors, for example, that are ongoing trials. Some will be presented at ACC, many that Professor Ballantyne is involved in. And I think that we need to continue to work in this area. But what about this other molecule, LP little a? there's an emerging role for this. This is a critical component of that residual risk that we talked about. And we've seen its association with cardiovascular disease, inflammation, and such. Lp(a) has been correlated with calcific aortic valve stenosis, peripheral arterial disease, coronary disease, heart failure, and ischemic stroke. We've got to be thinking about this, and the idea that for at least all of you should make sure you know your own Lp(a), and I hope you know that. And certainly you're measuring it at least once in your patients. And very important is that we need to understand these casual, continuous associations between Lp(a) and atherosclerotic cardiovascular disease, understanding that it's not a risk factor for venous thrombosis as we know it, that the very low Lp(a) can actually be associated with type 2 diabetes, and that it might be a new risk factor for aortic valve stenosis. So whether or not Lp(a) lowering therapies could have an important impact, they're all going to be in these phase 2 and phase 3 trials that I'll go through. But being a woman that I am, Lp(a) in women is an interesting one. This is a Copenhagen general population study of over 37,000 women and 33,000 or so men. And you see, over the age 50, we start to see the prevalence of Lp(a) coming out, but perhaps even more prevalent in women. And this is a very, very interesting concept to think about this in the Denmark studies. But more important is this 30-year risk of heart attack, stroke, and CV death in American women from the heart study that Paul Ritker has been working on in the nurses study that unfortunately has come to a halt based on this new administration at the moment. And hopefully it could go back on, because imagining how much data we have from this study now with 30-year outcome, where inflammation, cholesterol, and Lp(a) come out, very, very important in women. So there should be no woman who leaves your office that you do not know their C-reactive protein, high sensitivity, their cholesterol and LDL levels, and Lp(a). And it's for this reason that very important risk of heart attack, stroke, and cardiovascular death in American women correlates so well with all of this, with these three parameters of Lp(a), cholesterol, and high sensitivity C-reactive protein. So universal screening seems to be very, very much look at these curves and their correlation. Very, very important. And for that reason, Lp(a) lowering drugs are on the horizon, and we already have them. We get about a 25 to 30% reduction in Lp(a) from PCSK9 inhibitors. You could reduce it by 35 to 40% with lipid apheresis. But more important are the antisense oligonucleotide, the ASOs, that are being evaluated. The one that is really interesting is pelacarsen, that reduces Lp(a) by 80% from the phase 2 trials that we have, or the small interfering RNAs, very similar to inclisiran, where we have these three agents, both inclisiran as well as SLN 360 and olpasiran, where we know these are being studied. So let's go to the Horizon program. That's the program of pelacarsen, which is an ASO that I just described before, reduces it tremendously. This is the phase 2 antisense oligonucleotide pelacarsen, showing that 80% reduction. And the large-scale trial that is now will be reading out this year, phase 3 cardiovascular outcomes trial with large numbers of patients that will be reading out for major adverse cardiovascular events. That's the Horizon program. In terms of the small interfering RNA, with the Ocean A program, we've seen that olpasiran has the ability to reduce Lp(a) by 80%, And you'll see this large-scale clinical trial that's being run by Michelle O'Donoghue that is right now in follow-up and very, very interesting, and we're awaiting those results. There are also all these other important phase 1 and phase 2 programs that are ongoing that I think are also promising. So this is not an area to be left unnoticed. Lp(a) is right in front, and we can imagine that it will be then brought into our interventions as well. I want to touch base on this next issue, inflammation and cardiovascular disease. And it may very well be that inflammation will be an emerging risk factor. I just showed you the data from Paul Ritker's data on the women in the nurses study, but really important for us to also know that we have a lot of data that says in risk stratification, inflammation plays an important role. These are data from large-scale studies that Dr. Ritker was involved in, and this is a data that was just presented in the Lancet that I find intriguing. That very important role of inflammation, no matter how low you get your cholesterol, if you have high levels of inflammation, you still will be at a higher risk of cardiovascular events. And then those two together, very, very important, compounding the risk. So we've got to deal with both cholesterol, LDL, as well as inflammation. And it is this idea that the NLRP3 inflammasome and the ensuing cascade of inflammation that takes place when it is enticed is something for us to think about. We measure C-reactive protein as a biomarker. We know there is a vascular risk associated with it. It is the product of the liver, but just before that, it is IL-6 sitting there, right there, as the final pathway after this cascade of interleukin-1, 1 beta, 1A inhibitors. All of those are up there, upstream. And we understand that chronic activation is pivotal for this cytokine cascade and very important downstream product of what it is that we are measuring. Now, I show this because I think it's very important for us as cardiologists and interventionalists to understand this cascade and understand where the drugs are that we know about have been working on in the past. And also the idea that this could be something to be brought into myocardial infarction. And that concept, knowing that even about 50 years ago, the idea that there was inflammation in myocardial infarction has been well documented. That acute burst of inflammation with PMNs damaging and being an amplifier to that worsening elevation of the inflammatory pathways that we have seen in the acute setting, and then followed by this residual low-grade inflammatory cascade that we know is part of that inflammasome that I talked to you about. But also remembering, very importantly, that there is protection and healing that must be balanced when we are addressing inflammation in acute MI, especially in transmural myocardial infarction, because that healing is also important in that inflammatory cascade because it's a pathway to healing. So the early burst being very, very important with PMNs, IL-1 and IL-6, and then that later phase, smoldering low-grade persistent inflammatory phase that perhaps could be addressed in looking at some of these very interesting anti-inflammatory drugs. Now, colchicine, early on in recent MI and even in stable CAD, especially post-ACS, showed incredible benefit. And in fact, with both Colcut and Lodoco-2, there was real idea that maybe we should be adding colchicine, low-dose colchicine to patients. And this meta-analysis also showed that there was a 22% reduction in myocardial infarction, large reduction in stroke, large reduction in coronary revascularization, no reduction in cardiovascular death. But very interesting and brand new, straight out of the gates this past few months, the last 6 months, was the Clear Synergy OASIS 9 study by our Canadian investigators from McMaster, published in the New England Journal of Medicine, presented at TCT with over 7,000 patients who had a 2x2 factorial design after undergoing PCI after their acute MI, where they got placebo versus colchicine and then spironolactone versus placebo. And look at these curves hugging each other with zero impact on the ischemic endpoint of cardiovascular death, MI, stroke, or unplanned revascularization. Now, the study was run during COVID. It was supposed to be all MIs. It was really 95% young STEMI patients with a single stent, all undergoing PCI. And while this was completely negative and we can't really push holes in it, the truth is this is a very different population than the one I was talking to you about with the smoldering inflammation and obviously other risk factors. So where we are today with the European Society of Cardiology, their guidelines in 2023 giving a 2B A recommendation, and the brand new 2025 recommendations from our colleagues just past a week ago, giving the very same exact, so not a class 3, but a class 2B, leaves colchicine sort of in there and the inflammation pathway not thrown away. Remember, this drug was approved for these things on June 20th, just a couple of years ago. And it may be smart not to throw away the baby with the bathwater, because we have some data on CANTOS, post hoc analysis, where lowering the IL-6 levels through the IL interleukin 1 beta inhibition, which is how the drug works, canakinumab, showed an important, very, very big reduction in those patients, in MACE events, in those patients who achieved IL-6 reduction. And is there a way that we can go after that ligand right before it goes into the liver in terms of that particular cytokine with a drug? And this monoclonal antibody, ziltivekimab, is going to do exactly that. It's an IL-6 ligand inhibitor. When phase 2 trials look at incredible reduction. And the concept is that you could give it acutely and then chronically. And to note that we have a large-scale program for heart failure, CKD, and atherosclerotic disease, and now in acute MI. So for interventionalists and for this lecture, you should all know about the Artemis study that is going to have 10,000 patients. I'm co-chairing this with Adrian Hernandez from Duke. And this is a very large-scale trial that will be looking at a double-blind placebo-controlled trial of ziltivekimab acutely versus placebo in patients undergoing acute myocardial infarction. But let's move on from inflammation and go to the big, big burden and the big issue that we all have here in the United States and globally, the burden of obesity and cardiovascular disease. 1 billion people with obesity predicted by 2030. And knowing that most of us Americans are overweight and could fit into the high level of elevated body mass index. And so difficult in terms of what we clinicians need to do. And even if in the PCI, in heart surgery, in everywhere you look at, we've got issues with obesity. And now we have drugs that are ready for prime time, not only for perhaps enhancing and improving inflammation, plaque stability, and all the things we've talked about, reducing blood pressure, microvascular disease, but very importantly, working through this reduction of appetite, and reducing adiposities and reducing the fatty liver, improving kidney function. It looks like the drug of choice for pretty much everything. And the SELECT trial showed exactly that, that semaglutide reduced cardiovascular outcomes in obese patients, even without diabetes. And we now have combination drugs that are underway with large scale outcome studies with very, body mass index of greater than 27, patients without diabetes, intermediate risk for cardiovascular disease, 15,000 patients randomized to the dual pathway versus placebo. And it's going to be very, very interesting to kind of see the results of that. And maybe we just need to treat obesity and be done with it. But I think we've got to look at all of this in a multi-pronged approach. And finally, for all of our interventionalists, let's not forget about imaging. Let's make sure that when they come to the cath lab, we get optimum results, but also diagnose them beforehand. The fact that we now have the best imaging technologies, I find the CCTA is such an important addition to how I'm treating and evaluating patients as a risk evaluation for both anatomic and functional assessment, with the ultra high resolution CT being able to even look at plaque morphology, understanding myocardial perfusion and CT perfusion. It just seems to me like it could really be sort of upfront, and understanding that not all plaques are treated equally, and being able to have some AI enabled CT analysis to actually put our plaque evaluation into low, intermediate, and high risk. And there are trials now that are going to look at this in a way that we could absolutely evaluate the risk in a very, very big way. This is a huge outcome study that is ongoing for using CCTA AI algorithms with Clearly. But also for us in the cath lab, we have tools. We should use them, and we're underutilizing them. And now there is so much evidence that tells us if you look inside the vessel with intravascular imaging, combine it with physiology, you could have incredible results. Overwhelming evidence in reducing cardiovascular death, MI, and TLR. And why is it that we're only at about 15 or so percent usage across the United States? It's unclear to me. We're totally underutilizing imaging. We must do this to optimize PCI outcomes, especially in complex lesions. Please make sure you're imaging so that that patient who came under your interventional skills actually gets the optimum results before leaving the cath lab. And then, at last but not least, is this weird thing of, perhaps I'm against this, to be honest, this one, but I had to show you because this is a grand rounds and I want to be clear. But the truth is, preventing the vulnerable plaque from rupturing by putting a stent in it may not be the best thing after everything I just showed you, but this PREVENT trial seems to think so. But I would imagine in an open label trial that we should question these types of results, even though I'm an interventionalist and I love working with, performing interventions. But let's think about our outcomes by going from our intervention to prevention, because this is the best way for us to go forward to make our interventions durable. But also, let's go before that as you're evaluating patients to put the preventive strategies so that patient never has to go through multiple interventions. Thank you so much for your attention, and I look forward to our great discussion, and I hope that there is a little bit of time for us to have some questions. Thank you so, so much.